We have participated in a pooled analysis with several other groups that have treated patients that are newly diagnosed with multiple myeloma, treated with a combination Carfilzomib, lenalidomide and dexamethasone, also referred to as KRD. In this pooled analysis, merging 4 studies together has given us larger numbers. We've also been able to compare the outcome of patients who underwent bone marrow transplantation versus patients who did not undergo bone marrow transplantation after this combination therapy. The high points of this presentation is that the KRD regimen delivers very high responses. The overall response rate is close to 100% for patients independent of transplantation or not. Specifically, if you look at the complete response rates, patients who were treated with Carfilzomib, lenalidomide, dexamethasone alone, the complete response rate in this pool analysis is more than 70%. And if you add the transplantation, it's around 80%. Looking at long-term or more clinical outcomes, the study shows that the progression-free survival is about the same. Certainly, there are restrictions for the purpose of progression-free survival interpretations with regard to how long patients were followed on each of these 4 different data sets. But with the current follow-up time, the progression-free survival looks very similar. And that's also true if you look at a time point when the data is mature for overall survival. When it comes to safety, the KRD regimen is found to be very safe, very consistent with what we have seen previously. So I think in the current absence of a randomized phase 3 trial using KRD, I think it's quite reassuring to see that the pooling of 4 large efforts continue to build strong evidence that this is a very effective and safe regimen for newly diagnosed patients. The KRD regimen is already listed as a standard of care treatment for patients with multiple myeloma in the United States. The National Comprehensive Cancer Center Network, or NCCN guideline, stipulates which therapies are recommended and therefore also reimbursed. And the 2 main regimens that are listed in this guideline are the VRD and the KRD regimens. Until very recently, both these 2 regimens were based on phase 2 studies. In 2017, the first randomized study comparing VRD to RD was published. So therefore, the category 2A, which is what you get if you have a phase 2 study, was increased to a category 1 for the VRD regimen. The VRD regimen was initially put in this guideline back in 2009, so it took many years for it to be upgraded from 2A to 1, but both category 1 and 2A are recommended and reimbursed.